Hello, everyone. Thank you so much for joining and for, coming and spending your Wednesday evening with us. I am so excited for today's webinar. This is a topic that I see all over social media, hormone health and like women as we age, as we, go through perimenopause into menopause, and then you add breast cancer on top of that and, the long-term medicines that people can go on. And I know that there are so many questions out there about this topic. And so, I'm really excited for this webinar and to be able to share some of this information with you. So, with that, I'm going to introduce Dr. Kelly McCluskey, who's over here on my screen. I'm not sure where she is for you. I have known Dr. McCluskey now for how long? How long have we known each other? Almost 15
I
years.
was gonna say a really long
A
time.
really long time. So, I have seven children, and Kelly has delivered three of the seven.
Yep, just the last three.
The last three, yeah. And so I know her very well, but also, just have been really inspired by her work and her story, what she will share with all of you tonight. But so, Kelly, why don't you introduce yourself and tell us a little bit about your background?
Yeah, sure thing. So, like Karen said, I've delivered her last three babies. So, I am an OBGYN here in the community. I primarily deliver over at Kettering Hospital here in Dayton, Ohio, and really love my group, love what I do, and was kind of just bebopping around my life thinking, I'm going to take estrogen and hormones until, for menopause and do all those wonderful things until they rip it out of my cold, dead hands. And then at the age of 42, got diagnosed with hormone positive breast cancer, which sort of put a damper on those dreams. So I did surgery, chemotherapy, radiation. I'm now coming up on 4 years from diagnosis, which is pretty wild to think about. Yeah, I kind of
I
forget
didn't
that
know
it
it had
had been
been
that
that
long.
long. Yeah.
hmm Well, I
Wow.
can tell by the length of my hair, right? So it's
Yes.
almost as long as it was before I was diagnosed, which I get very excited about when I put it up in a ponytail. And I know that other people on this call, I'm sure, can relate to that. So, there were a lot of decisions that had to be made. And, I was in my early 40s at diagnosis. I had kids, I had, a spouse, I have, hopes and dreams for myself and desires for my life to continue as it had been. And that was difficult. And there were things that came up with that. And, as a gynecologist, I had talked with women for a long time about hormone therapy in various settings, whether that's just for menopausal symptoms or in the setting of a hormone positive cancer. But then it just put a little more personal spin on it and allowed me to really examine the evidence, but also, what really is important to us as we age with a history of a cancer that is hormone fed. And so what can we do to make our lives continue to be what we want them to be? And I think it's really important for us to keep our quality of life as in addition to the quantity of life. And that's part of what I love about Maple Tree, because Maple Tree really puts onus on us to keep our quality of life in addition to quantity of life during treatment and afterwards. And so I was part of Maple Tree long before I had cancer. Um, it's very strange how God puts like people in our lives and situations in our lives. And so Karen and I had met each other through a Bible study, actually. And then we ended up, she became my patient. And then I became a board member on the board for Maple Tree. And then I became a client for Maple Tree. And I benefited from not only knowing them on a professional level, but also on a personal level there. And I exercised every day when I was in my treatment, and that didn't look the same every day, but it was about moving my body every day. And that was really important to me. So that's kind of my journey. I'm doing really well. And I'm very thankful for everybody involved in my care. And I'm also thankful that the discussion around hormone therapy, especially in the setting of breast cancer patients, has been getting better and better over the last couple of years, and I have really benefited from that myself personally. But also, I see my patients benefiting from more information that we have, and it's getting better for us. So I want to give you guys encouragement at the very front end of this, that a lot of the things we're going to talk about are actually going to be good. So it doesn't have to be the end.
I love that. Thank you so much for sharing your story and just for all of that. That was really great. And I know that that probably helped a lot of people that are going to be watching this. So thank you.
Yeah.
So, everyone who signed up, you guys had the opportunity to send in some questions. So, we have kind of compiled all of those questions and given them to Dr. McCluskey, and she's going to go through and try to answer them. Also, though, and I hope this is okay, I didn't ask you this, but can they also put some questions in the chat if anything does come up? And
Yeah.
I can
Can you
help.
moderate that for me?
Yeah, I'd be
Okay.
happy to. If you put them in the chat, probably what we'll do is save them for the end. But I'll just kind of let you take it away.
Okay. One of the things I want to be very upfront with this is that, I am not your personal physician. So anything I say here is just advice for you to go and speak with someone who's on your care team, whether that's the oncologist, gynecologist, all the people, and we all try to work together. So I work very closely with our breast surgeons here in town and our hematology oncology colleagues who work with my patients who have cancer. And so I encourage you to have a multidisciplinary approach with your team. So I'm going to try and keep things more broad, general strokes as opposed to like personalized, like very specific questions on things. But I think there's enough here that can be a little more broad that can be really helpful for people. So one of the things I wanted to talk about briefly is just the definition of menopause, kind of what that looks like, and then go through some of the major treatment hormone blocking agents that are used in hormone positive breast cancers. So, menopause is officially, the diagnosis of menopause is 12 months without a menstrual cycle. There are lots of people that have 12 months without a menstrual cycle that are maybe not in menopause, people with a hysterectomy, people that have had an ablation where they burn the lining of the uterus, people who have an IUD in place that stops their periods, people who are on continuous birth control pills. So it's not a great definition, but if you have none of those things and you don't have a period for 12 months, then you are essentially in menopause. Average age for that is 51. Um, Early menopause is anything under 45. Premature menopause is anything under 40. So that's kind of our categories. And the reason I bring that up is because that determines what is the most effective treatment to keep you from having a recurrence of a hormone positive breast cancer when they give you a hormone blocking agent. And so there are lots of things that happen in menopause just in general. And those things can happen the same for patients that get chemotherapy and their ovaries are no longer functional. Say you're in your early 40s and you get chemotherapy and then your ovaries just stop working, or they stop working for a period of time and then kind of half-heartedly come back. And so a lot of those things are the very typical stuff that you hear, right? Hot flushes, night sweating, waking up at night, the brain fog, muscle aches, joint aches, word finding difficulties, um, hair loss, mood changes, frozen shoulder is a real big one. Inner ear itching is also one that I've heard from patients. Like they get a really significant itching, like way in their inner ear. It's very bizarre.
That's
Um,
so uncomfortable when that happens.
it is, but and when they've been on hormone therapy with estrogen, that like disappears. It's the most bizarre thing ever. So, and I think we're finding more and more of this, and we're seeing a lot more menopause talk in our spaces, both women talking to other women about the process, because it used to be like very hush hush. You didn't complain about it because you just didn't. You like got your fan and you fanned yourself, or you went and you stood in front of the freezer or whatever you did in the 50s, but you didn't talk about it, right? Just like you didn't talk about your periods and you didn't talk about all the other things. And I think we're doing a much better job about talking and being more verbose with each other about that. Um, and also in, of course, the social media spaces, you find influencers on every social media platform, from podcasts and educational videos to TikTok and Instagram and all the in-betweens. Some of the information is really great. some of the information is really terrible and not necessarily something I would recommend following. And it's so hard to know the difference, right? It's kind of like AI and images right now, where you can't trust anything you see right now. Everything we see, we have to really examine and figure out whether or not we can believe that. And that is very true in the social media space around the perimenopause discussion. So even when someone comes up in your feed and they say, hey, this is what I had and this is what we should all be doing, you really need to take that with a grain of salt and go to, you know, find their sources. If they're trying to sell you supplements, probably not going to be your best source, right? If they're trying to sell you a weightlifting plan or whatever, also probably not your best source. It's not that they're bad sources, it's just that they have an ulterior motive, a secondary gain. So there's some really good places. I highly encourage you to check out the Menopause Society. So that is an international organization. They have a website you can go onto, and there's a lot of good information there. So that's kind of the broad menopause picture. So the reason I bring that up is because if you are not in menopause yet, so you're premenopausal, meaning still having periods, or perimenopausal, meaning having periods, but maybe you're having some of those symptoms, or maybe the periods are a little irregular and we're getting closer to that time frame, but we haven't actually stopped yet. The medication that your oncologist will recommend to you is most likely going to be different than if you are a menopausal female. If you are 51, 52, 65, 70, and you have a diagnosis of breast cancer, they're going to recommend a different medication for you than they are for patients in the premenopausal space. Um, so that's usually in the premenopausal and perimenopausal space, tamoxifen is what they recommend. And then in the postmenopausal space, it's usually an aromatase inhibitor. So some examples of that would be letrozole, arimidex, exemestane. Kind of those are some of the names out there. There are other medicines that will be recommended to people that have like higher stages of cancer, like Kisqali and some of those other medicines, and those are a little bit different. And I'm not going to go into those because it's a little more complicated. But the basic difference between these two that are the bread and butter of treatment for hormone-fed breast cancers is tamoxifen works by blocking the estrogen receptor at the level of the breast tissue. So if you can imagine, you have a little receptor here. I'm trying to look be in my screen. You have a little receptor here, and normally estrogen would come and attach itself to the receptor. Well, tamoxifen just basically blocks so that estrogen can't attach to the receptor so that it doesn't grow. And that does it at the level of the breast tissue, which means that if your ovaries are still functional, it will block the estrogen coming from your ovaries or from your peripheral fat tissue, and it will stop it from attaching to the breast tissue, which is great because it stops it from going to the tissue we want it to stop it from, but it doesn't necessarily stop estrogen from circulating in our bodies. So our bone health doesn't suffer as much. Our vaginal health, some of the other places don't suffer as much. It's still not awesome. There are definitely side effects, hot flushes being number one. Um, and then also some risks like a slightly increased risk of blood clots in your legs that can travel to your lungs. It's called a DVT. And also an increased risk of a cancer of the uterus, which is terrifying, but very, 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 very rare. And that's something that you and your gynecologist, they need to know you're on the tamoxifen so that they know that you have that as a risk factor. And so they'll be a little more aggressive about evaluating that for irregular bleeding. The aromatase inhibitors, so the letrozole, aromatase inhibitors like aromacin, exemestane, those work a little differently. The goal with those medicines is to block all estrogen in your body from being formed. So your ovaries are not making estrogen. But now I'm going to block the peripheral fat tissue because we all have fat cells that will make a certain compound that can then be turned into estrogen. And that's called aromatization. So that's where the name aromatase inhibitor comes from, is that it inhibits the fat tissues from changing from that compound, so it's an androgen, into an estrogen. So that eliminates all estrogen from your body. So for those patients that are on the aromatase inhibitors, your side effects are the joint pain and the arthritis feeling, and the bone loss is wild. The muscle loss is wild. Like it is menopause to the max. Like your vagina is the Sahara Desert. It is really not great. So, so that's kind of the difference between the two. But the recurrence rates in patients on aromatase inhibitors is lower than the recurrence rates on tamoxifen. And that benefit to being on the aromatase inhibitors, we'll just use letrozole as our example. The benefit to being on letrozole increases the more you move into menopause. So if you're premenopausal and you're using tamoxifen and an or aromatase inhibitor, there's a little benefit to the AI, just a little one. And then if you're perimenopausal, there's a little bit more. And if you're postmenopausal, there's definitely an improvement. So the most of the patients that are postmenopausal are going to be on an AI. Um, so that's kind of how those two main categories of medications work. And there are reasons behind why we use them that way, but also reasons why we may change from one to another. If you can't tolerate the aromatase inhibitors, your oncologist may be might change you to tamoxifen because those side effects are too much. And it doesn't mean that you won't get any benefit from it. It just means it might not be quite as much as the aromatase inhibitor. So you have your diagnosis of breast cancer. You have gone through your active phase of treatment, whatever that may look like for you. So it might be surgery, radiation, chemotherapy, any combination thereof. And now you're going to be on this medicine for anywhere between 5 and 10 years. That's a long time to be on a medicine that's going to make you have these side effects. So you start taking the medicine and you start having side effects, and you go to your gynecologist and you say, I am 45 years old and I never want to have sex because it is so painful. I just don't know what to do. There's research out there in 50,000 women that says that we should be offered vaginal therapies for painful intercourse, or it's called genitourinary syndrome of menopause. And genitourinary syndrome of menopause can be the vaginal dryness, the painful intercourse, the increased UTIs, the just general feeling of irritation in the vagina, recurrent bacterial vaginosis infections, things like that. It's just the tissue of the vagina without estrogen is very uncomfortable. Um, what they have found is that women who use vaginal estrogen are at no increased risk of recurrence of their breast cancer for hormone positive cancers. They should be offered this as an option. It may not be your first choice, and we can go through all the options as before we get there, but it should be something that is offered to you as an option for treatment. Now, that is just the vaginal treatment with estrogen. When we talk about systemic hormone therapy, that means taking either a pill or a patch or something like that that's going to replace estrogen in your whole body. That's a more complicated discussion. It shouldn't be a hell yes, but it shouldn't be a hell no either. So I think it is a nuanced discussion that you should have with your physician about how these side effects are affecting your quality of life. Just like I talked about in the beginning, quantity is great. But if there's no quality to it, then what's the point? If you can no longer do your job because your brain can't focus, because you're not sleeping, because of all these things, then maybe we should be talking about some type of hormone therapy. If it's the hot flushes and the night sweats, there's lots of options that are non-hormonal that you could try first if you wanted to. And I think are probably very reasonable to start with. Things like there's a medication called gabapentin, which is we use it a lot for nerve pain, but can also be helpful for hot flushes or night sweats. Some of the antidepressants can be very helpful in that category. And then there are two new medicines that are in this new category that basically work on the thermostat part of our brains. So if the primary side effect that you're having right now is, the hot flushes and night sweats, it's called Veoza and Linquet, and they both are in this category of medicines that try to tell our thermostat that we're okay, that we're not dying. They're not being put into a tar pit of volcanic fluid. It's really terrible. The hot flushes are just, I walked into a patient room one time. I just literally had sweat like on the mustache part of your face, the really embarrassing thing. And it was just behind my ears and behind my knees. And I couldn't even concentrate on what that person was saying because I was so focused on whether or not they could see the sweat literally dripping off my face. It was so embarrassing. So, those the other medications can be very helpful for that because they do tell our brain that we're doing okay. And it's a non-hormonal medication. So if we can manage the symptoms and you do okay with some of these non-hormonal options, great. That's wonderful. That's something that we can definitely, stair step up. But if you have gotten through these other options and it's not working, and you really are suffering, we should be having this conversation. Women should not be forced to suffer for decades because they had a cancer when they were in their 40s, 50s, that kind of thing. So, when someone asked a question like, why are some doctors okay with hormone therapy and others are not? I think there's a lot of reasons for that. And I want to encourage you to find people that are comfortable talking about it. It is, we are getting better as gynecologists at discussing it. Um, and really understanding the nuance behind it. But it's complicated, and there are people that specialize just in that very narrow niche market of menopause health. And if you can find, like I said, the Menopause Society, they do have a certification that you can get for menopause health. And so if you want to find a provider on that page in the local area that has been certified in menopause health, that's great. It doesn't mean that the person who isn't certified in menopause health is not educated on it. It just means they haven't gotten the certification. But it's a place to look if you want a place to start to look for someone. Um, so I'm hoping to get that certification this year and, work forward on that because I talk about it every day, all day. Especially, your patients sort of age with you when you're in OBGYN. And so my patients started in my age group when I was first starting. We were all in our like 30s and everybody was having babies and all those wonderful things. And now we're all in our 40s. And so then we're somewhere in our 40s and we're all having the same conversations about, menopausal health and things like that. And so it's important for me to be able to talk to a lot of my patients about that. But that's a place to look for a provider that it might be more comfortable talking about hormone therapy. But we should all be, as gynecologists, better about that than we are. If I could make a plug, though, it is a complicated, long conversation that we want to make sure that we have the right information from you to be able to provide the right information to you. And it's not something that we can address along with your annual wellness visit, right? Like we have a lot of things that we go into when you come to your annual exam. And a lot of my patients will come in and they'll be like, yeah, I was waiting for my annual exam because I have, this and this, and I'm having hot flushes and night sweats. So what I usually try to tell my patients is like, hey, I have this packet of information, and I usually give them my little menopause packet. And I'm like, look, read this over. It's got some good information. It's got some good resources. Come back, bring all your questions to you, and then we can sit down with a dedicated appointment to really discuss this and figure out what's the best thing for you. And that really allows me as a physician to spend the time really listening to what are your primary concerns, what are your risk factors, what is the timing of all of this, and then moving forward, get you on what needs to be done. So having more time to do that. Let's see. What about is vaginal estrogen safe on letrozole and hormone positive cancer? And we talked about that. That where you're okay with it. I think more people are uncomfortable when you're on the aromatase inhibitor because the whole idea is that it's going to block all the estrogen in your body. And now I'm going to give you estrogen in your vagina, which will give you a minuscule amount to circulate in your body. And then it doesn't appear that we lose the effect of the aromatase inhibitor, like the improvement for our recurrence rates does not decrease. But it is a shared decision making with you and your doctor. And that can come from your oncologist or your gynecologist.
Yeah, that was actually a question that I had was who do you go to manage some of these issues? Your oncologist, your gynecologist, primary care?
It depends
Okay.
on who's comfortable with it, right? So a lot of, our family doctors, they are the workhorses of the medical world. And I do not wish anything ill upon them because they have to know so much about so much. And our oncology colleagues have to know so many things, and information is just coming at them rapid fire right now. Like there's so much research and so much new coming all the time for them. And that's true of all of medicine, but I think talking with your gynecologist is really important because we are the experts at sexual health, right? Your oncologist is great and they deal with it a lot, but that's not their job primarily. Their primary job is to keep you alive and ticking and to the best of your, in the best health that they can get you. And sometimes um that means that they don't have time to address some of these sexual health questions or functional health questions. And so a gynecologist can be a really important person to go to. Now, I know a lot of us maybe have gotten away from going to the gynecologist, especially as you get further and further away from having pregnancies. A lot of women don't think that they need to go back. And so that's okay. Just reestablish with somebody new, have a conversation with someone about it. We have lots of really great gynecology colleagues all over, the community and all over the country. I know this is not just a Dayton focused, event, but, um, I have colleagues all over the world that I talk to and exchange information with and talk through studies with. And we really do care about your health and what we can do to make your quality of life better. So yeah, I think any of the three of them are fine if you want to bring it up. And if they're comfortable with doing it, great. But if they're not, then it's time to find somebody who is. Um, Testosterone therapy is a little bit different because, the breast cancer markers are estrogen and progesterone, right? And so the testosterone therapy, while in short term does not appear to increase risk, we don't have a lot of good long-term data on testosterone yet. It's coming. I think it's there. It's in process. It just hasn't been a focus, and I think that's been a blind spot of the hormone therapy research market. But I think they're coming around to it, and I think we're going to get more information on it. It's just not there yet. So I don't have a good recommendation on that yet. Um, but again, it's something that you can talk about, and a lot of people will use it for libido issues after menopause. So. Um, so as far as hormone blockers, most oncologists are going to tell you to take the hormone blockers. We talked about the pros and cons of each kind. Um, how many years they are taken depends on your specifics. So I'm not going to get too much in the weeds, but it's usually it started out when tamoxifen first existed, which was probably 20 years now.
No thanks.
Sorry. So with tamoxifen, that came out and it started out with just 5 years of treatment. But now they recommend 10 years for a lot of people with that. And that will depend on your specific tumor type and if they do an oncotype, which is just a kind of a test that they can do on how aggressive that cancer might be at coming back. So that's a little bit more out of my wheelhouse as far as whether or not we should be worried. Um, but but usually the 5 to 10 years is pretty typical. And when we talk about estrogen suppression for that long, we need to talk about the long-term consequences of that. So big long-term consequences that we're coming to know better now, obviously our bone density, right? We really care about that. Our peak bone density is at age 30, starts going downhill slowly after that. Once we hit menopause, it's going to go down more significantly. And if that's the case, then when we have these medications that block the estrogen even earlier than our natural onset of menopause, or, block all the possible estrogen from our bodies, our bones are really going to suffer. But decreased bone density leads to osteoporosis, which then can lead to increased risk of hip fracture, which leads to decreased independence. So once a woman breaks her hip, independence goes down significantly as far as their ability to stay living in their own home and taking care of themselves and things like that. So it's a really important part of our long-term health and well-being. There are medications that we can take that will help with bone density over the long term, that are not estrogen. So things like Fosamax, so those things that help our bones not break down so fast. And then if you are osteoporosis already, there's one called Reclass, which is an infusion once a year, or Prolia, which is an injection 2 times per year. And there's some other medications that are out there as well to try and help with bone density. Best thing you can do is eat well, lots of dietary calcium, get some vitamin D, making sure that you are taking care of yourself in that regard. And then resistance or weight bearing exercise can be very helpful for trying to continue to have good muscle and bone mass as we age. And that's across the board, whether we have cancer or not, whether we're on these medications or not. As we age, we really need to work hard at trying to make sure that our bones and muscles stay healthy. Um, so, other long term effects are cardiovascular, memory, so risk of dementia, um, colon health. All of these things are improved by estrogen, which just, again, it hurts my soul to have to say that I probably won't be taking estrogen and will have gone through early menopause because of my cancer. And so I'm really focusing on a lot of the other things that I can improve in my lifestyle in order to limit those risks. So for cardiovascular health, making sure I'm getting the appropriate amount of exercise, making sure we're eating healthy, making sure we're watching our cholesterol and high blood pressure and all of those things as well. So we can mitigate some of this by lifestyle changes, but we can't fix it all. And I don't know that that's something that we will ever be able to fix entirely, because we are deficient on this hormone for the most part. Um, I think that the side effects that people get through menopause when they go through it, because of cancer treatment, seems to be more intense than it is when people go through natural menopause. Not to say that natural menopause is a walk in the park, because it's certainly not. And it's certainly not a linear process, right? But when you have when you are premenopausal and then you go through treatment that then subsequently either stops the ovarian function because of the toxicity of the treatment that you went through, or you are intentionally suppressing the ovaries because that gives you the best benefit in long-term recurrence or survivability. Um, Both of those things can lead to the long-term consequences that we're seeing. Um, Someone asked what symptoms are expected and what should be a red flag that you need to call your doctor. And I think when we're talking about symptoms that we get on medications that suppress our hormones, anything that causes cardiac type symptoms like chest pain, jaw pain, pain in the neck, those worrisome things for cardiovascular disease. If you're short of breath when exercising more than you normally are, if you are having loss of vision in a vision field, all of these are reasons to give your doctor a call. And really, we want to hear from you regardless of what's happening. If you think something is not right, let us know, because that's the only way we're going to try and figure out, is it this or is it not? And there are options to try and switch around medications to make that a little bit better for you. Um, I feel like I am talking a lot. Do we have other specific questions, Karen, that I'm missing?
No, I'm so interested in everything that you have to say. So
I hate feeling like if I'm talking at people and you guys are getting bored, please feel
no,
free.
I mean, the question that I had, and I thought that you did a pretty good list of this, but if you are in a situation where you're not able to take estrogen and you are
Mhm.
experiencing some of those symptoms that you described, but then also you want to reduce your risk for down the road future things. So you mentioned lifestyle, so exercise. Is it just regular exercise guidelines or particular type of exercise?
So the biggest thing is going to be strength and resistance exercise. You still want some cardiovascular in there, but the strength exercises are going to be super important for bone health, because if you don't put stress on the bones, it's like I heard somebody say the analogy of a tree. If you have a tree and you grow it in a nursery and there is no wind, that
Mm,
tree will be weak because it
mm,
will never have had to work against the stressors of the wind. Our bones are the same way. If we don't have the stress of putting pressure or pulling or pushing against the bone and having the muscles push and pull against the bone will not be as strong.
wow.
So when you talk about like when astronauts go to space, which I am fascinated by this whole Artemis
Hmm.
thing, right? But when they go to space and they are weightless for any given time, they actually lose muscle and bone mass because they don't have the resistance against their bones and muscles to help continue to keep them strong.
Mm.
So it's something that we need those resistance exercises for. The other thing that I really encourage basically every woman across the board when you get into your 40s and 50s is start working on balance and core strength.
Mm.
It's going to help keep you from falling, which is going to help keep you from breaking a hip, which especially if you have osteoporosis or low bone mass, that's going to be really important for you. So, the flamingo stands, it's simple as like standing at your counter at home, having a hand there just in case you need any balance help, and then stand on one leg 30 seconds at a time, 2, 3 times a day, switch legs, make sure you're trying to do both. Really work on tucking your bottom under and kind of holding that core steady. Um, and then, Pilates and yoga are wonderful for that as well. Tai Chi is actually really wonderful for that. And it's a uh, impact way of trying to help with some of those strength and balance and coordination and all of those things. So those are really, really important.
Yeah. Yeah. That's super helpful. So if someone is on one of these, tamoxifen or AI or one of the things that you described, and they're experiencing symptoms, you know, at what point what can you do to help, I guess, manage those symptoms? But then at what point do they, because I oftentimes will hear of people going off of a particular medication because the side effects were so bad. So like what are their options when it comes to that?
It depends on the symptom. So the joint pain, arthritis, hand pain, muscle tendon stiffness that you get with aromatase inhibitors, and specifically a lot of patients, if they aren't able to handle one, might be able to handle a different kind. So their oncologist may switch you from letrozole to anastrozole to exemestane and kind of may hop you around or give you a drug holiday where they give you a small break,
Mm,
where you say, okay, I can't do this straight through for 10 years, but I could probably do 6 months and take a month off, and then 6 months again and take a month off, and kind of do it that way and just sort of like get yourself there. Or if the side effects of all of those medicines are too much, then they may switch you down to tamoxifen, which traditionally are the side effects are not as intense because,
mm,
again, it's not blocking all the estrogen in your body.
right,
It's only blocking it to the breast tissue. And so some of the other pain that you get is not quite as intense. It doesn't mean that it's not there. It just means that it's maybe a little more tolerable and you might be able to get through the full treatment.
mm,
Um, but it is hard. I mean, I'm on because you don't start that until you're done with your active treatment. So I'm really only 3 years into 10 years of
right.
taking medication. And for me, I decided tamoxifen was the right choice because I was premenopausal. But
Mm,
at the 5 year mark, the plan is to switch me to an aromatase inhibitor. And I feel that for you guys. Like I feel that nervousness about what it's going to be like when I change.
mm,
And am I going to be able to handle it? And I've heard all these horror stories. And so it's not just you. Like I feel the same way. I don't know exactly how my body's going to handle that.
mm,
So, and if would it be the worst thing in the world for me to just switch back to tamoxifen? No. But
mm.
the idea of staying on a medicine for 10 years in general is just a little overwhelming.
Yeah, that's really daunting.
Yeah.
Are there, any like supplements or natural options that might help or, alternatives or anything like that?
So for some of the hot flushes and night sweats, we kind of went through a little bit of those
Mm,
other options that are non-hormonal, but as far as natural remedies and things you can do, um, when I talk to patients about it, I talk about magnesium is a great option that can help you with sleep. It can help you sleep a little bit better, especially when you're waking up at that 3 a.m. It's 2 to 4 a.m. every
mm,
single night, every single night. And it's not just, it's like every person I talk to, it's around that time.
mm,
And it's somewhere in that time frame when our bodies are supposed to get a little bit cooler in the nighttime. And if you don't even if you just stay the same, instead of dropping down a couple of degree,
mm,
1.5, 2 degrees, your body feels like it's just sweaty and hot and clammy. So there are devices where they'll like a mattress pad that'll run water through the mattress pad, and I put that out there for everybody, and they have specific temperatures. And if you and your husband are on different wavelengths, like mine and my husband, I would like the bed to be very cold, and he would like the bed to be very warm, which is not typically how things go, but that's how it is in my bedroom, so it's fine. So that mattress pad splits in the middle, and he can keep his at like 85 degrees, and I keep mine at like 79 degrees, which is interesting because it's like your body temperature is 98, right? And so even 85 degrees doesn't feel as hot as what you would think it would be. It's not like you're like in a swimming pool that's 85. But
Yeah.
that's a great option. There's a bunch of different manufacturers that make those out there. One of them is called the Chili Pad, and it basically looks like a little CPAP machine that sits under the bed, and it runs distilled water through these little tubes in the mattress pad and keeps the mattress warm and cool, and can sometimes be just a natural way to kind of mitigate some of those symptoms in the middle of the night. And the same thing, like that people have been telling us for decades, get a fan, have a fan in your purse, have an ice pack here and there, and wear light clothing and multiple layers. And those are all great suggestions. They're just, they feel a little, trying to find the right word for it, patronizing, I think. When you want to just, shake your fist at them and be like, I wish that you, what do you have to go through? And it's, the
Uh-huh.
answer is not a whole lot. And so,
Very nice back.
yeah, yeah. So, but I mean, I do have a purse fan. I take it everywhere with me.
Mm.
Airplanes are specifically very bad because, the airflow is not great. And so I just sits on my little thing in front of me, and I can turn it on. It's a charger, it's a flashlight. You know, so
Right.
you can do some of those things as well.
Mhm.
As far as like estrogen or black cohosh or some of those other things, you can do those, but I caution you because a lot of those things are estrogen derivatives. So estrogen has an estrogen derivative of soy in it. And if the goal is to not have any estrogen in our bodies, do we really want to do something that not only is it an estrogen derivative, but it's also not even regulated in any way? A lot of the natural supplements are not regulated in the same way that pharmaceuticals are. Not to say that pharmaceuticals are without their downsides, but um, I would caution you that that's maybe not the greatest of ideas.
Mhm.
But there are, for the vaginal symptoms, if you don't want to do vaginal estrogen, say you're not comfortable with that, there's lots of options moving up to that, right? So I go through my whole vaginal spiel. There's different types of lubricants. Coconut oil is my favorite thing to recommend to people. It's
Mhm.
in the kitchen, solid state coconut oil. You take a little dab will do you. You take a little dab on the finger, put it in the vagina, smear it around a little bit at the opening because that's where a lot of women have discomfort is right at that opening part. You can even use it on the penis, and you just kind of rub it on your hands and rub it on the shaft of the penis. Use it as part of your foreplay, and it can be very helpful. And it's around the house, and it doesn't, require you to buy anything online, or, there's no preservatives in it. It doesn't irritate the vaginal tissue as much as some of the other things. But there are water-based and silicone-based lubricants. And then there's something out there called Reverie, which is an over-the-counter product. And I don't get anything from them, but there are studies behind it for efficacy. It's hyaluronic acid, just like we use on our faces to try and keep our beautiful youthful glow, which is another thing that we can talk about. But the hyaluronic acid that we would normally use on our face, it comes in a little suppository, and you put it in the vagina 2 to 3 times per week, and it can give just enough moisture to make intercourse less uncomfortable. And so for patients that are looking for something that's maybe not an estrogen to try before them, those are all great options. They're over the counter, easy to get. There is another medication called prasterone, and that is a suppository you can put in the vagina every night. That is kind of like a steroid derivative. It pretends like it's estrogen to the vagina, but it isn't. And that one is okay to use as well. It's just really hard to get covered, honestly. That's a prescription that I struggle getting covered for my patients, regardless of their needs. So I'm willing to fight that fight for you guys, but just know that it may take some effort on your doctor's office part to be able to get that one covered.
Mhm.
And then, like the weight gain that we see in menopause in general, we do see a redistribution of our fat, which is you can stay the same weight or go up just a few pounds, but you see that like spare tire, like that just below the belly button, above the pubic bone, fupa, for lack of a better term. So it's just an increase in that deposition of fat in that area. Um, and you can try and do exercising and things like that, and it just seems to deposit in the area. And we're not really sure if there's a great way to make that better. Obviously, there's some people that genetically don't have that, and then there are some people that genetically just have more of that. But eating well and lifestyle changes in that regard are going to be your best bet. Um, GLP-1 medication, someone had a question about that, and you can use it alongside an aromatase inhibitor. I don't think it's a magic bullet as far as menopausal weight gain goes, but where there is a component of insulin resistance, meaning as we age, we do not get the sugar out of our food as an efficient fashion as we used to. So if we used to eat an apple, 25 grams of sugar, we would use 24 grams of that sugar and maybe store one.
Mm,
As we age, we might use 20 grams of that sugar and store five. And in the storage is fat.
mm,
And so it creates more fat cells. And so a lot of women are finding that they have to kind of monitor their sugar intake, eat a little bit more of a sugar neutral diet, meaning cutting out excess sugars is always a good idea.
mhm,
They're not good for us in general in the excess. Nothing is good in excess, right? But sodas should be cut out. Alcohols are also a big sources of sugar because we like the fruity drinks. But even if you're like a wine or beer drinker, alcohol can increase hot flushes. It can increase the discomfort to the way that you sleep and the way that you feel in your joints and things like that. So, alcohol consumption, I would recommend decreasing or eliminating that um, as a way to help improve your health and well-being.
mhm,
So those are some of the big takeaways. Obviously things easier, low-hanging fruit for everybody knows we shouldn't be smoking, we shouldn't be taking recreational drugs, but alcohol's hard. There's a social aspect to it, and it's nice to go out with your friends and be able to do that with them, but it may not be the best choice for us.
mm. Yeah. Um, what about if you have another chronic disease or comorbidity along with cancer and you're on hormone therapy? Are there interactions or things that you have to kind of watch out for?
It depends. Most hormone therapy does not cross over. I know that some people specifically mention like thyroid or diabetes or celiac, and
Mm,
most of them don't cross over with any of those. You can do them in combination with most things. And there are women all over the world that take it that don't have cancer that have all of these other comorbid conditions as well. One of the things that I do watch out for is your cardiovascular risk score. So as you age, your cardiovascular risk score changes with your cholesterol level and your whether or not you have diabetes and whether what your baseline insulin is and some of these things. And so there's a calculation out there that's a cardiovascular risk score. And if you're over a certain amount, then it's one of those things where we really have to sit down and say, hey, is this going to be the best thing for you to be on hormone therapy, even if you don't have cancer or never had cancer or didn't have any risk? So, the cardiovascular risk can be a big deal to
mm,
try and eliminate that. Because I mean, we're trying to improve your health and not work against it. And if you have been menopausal for more than 10 years, it's probably not something you should initiate.
mm,
So that's a really big caveat that we are looking at is the timing theory. So there was a giant study in Denmark, and they looked at risk of breast cancer, and this is in non-cancer patients. Let's, go back from there. But they looked at women that started hormone therapy within the 10 years of their final menstrual cycle versus women that were started on hormone therapy after the 10-year mark of their final menstrual cycle. So if they stopped having periods at 51, they started on hormone therapy after the age of 61. And when they did that, they found that those women that started later did not get the benefits and maybe even had increased risk of stroke and heart attack if they started too late.
mm,
Versus if you started closer to your final menstrual cycle and when you have when that all happens, you actually can improve your cardiovascular health. So there's a timing theory to it. And again, that's data that's all coming out, and we're learning new things every day about it. And I think it's just a fascinating topic.
mm,
And as time goes by, we're gonna parse out a little bit more and a little bit more.
mm.
So
Very cool. There is a question in the chat. If vaginal estrogen is being used, should vaginal progesterone also be used with it?
You do not have to do that. So if you are just using vaginal estrogen, even if you have a uterus, it is such a small absorption to the rest of the uterus and everything that you don't need to have vaginal progesterone. But that's a great question because when you have, and maybe some of you guys don't know. So if you have a uterus and you're doing hormone therapy, you should have estrogen and progesterone. If I give you estrogen alone, like systemically, not just through the vagina, but like if I'm giving you estrogen as a hormone therapy treatment and you have a uterus, you need estrogen and progesterone. And that can look a lot of different ways. Um, but if you just do the vaginal portion for painful intercourse or dry vaginal tissue or things like that, you do not need to do progesterone supplementation.
Mm,
Or if you don't have a uterus and you do systemic therapy, you do not have to have progesterone
mm,
because it's mainly there to protect the uterus.
mm. Okay, cool. Well, I think you hit all the questions.
I tried to get them
I've
all.
been
She
trying to
gave me a
follow.
three-page list.
I
So
know. I've been trying to follow along, make sure that we have everything. But I guess, just final takeaway, if you could give us one or two key priorities to focus on, particularly the breast cancer survivors, what are some things that we can focus on for our long-term health? What are your top two priorities?
So my top two priorities is finding out what's important to you for your quality of life.
Mm,
If that is your sexual health, talk to someone about it. We do not have to suffer. And number two is it's you have to do the diet and exercise. We
mm,
have to. We have to take care of our bodies. I know we feel like they have betrayed us in so many ways, but we can treat them well and we can fuel them with the things that we need to fuel them with, and we can continue to help our bodies be the best that they can right now.
mm.
So those are my two big ones. But really, quality is important.
Mhm.
Don't suffer.
Mhm.
Don't
Yeah.
suffer in silence. I mean, I can't
Yeah.
fix everything, but we can definitely talk through.
I think that's such a good takeaway is that there are things that we can do. And, just because this thing here might not be where we want it to be, we have agency and there are things that we can do where, we can still thrive in spite of some of these things.
Yeah, it's really interesting. There's some cancer centers that are getting better about having more of a multidisciplinary approach to the overall body health. So Maple Tree being one branch of that, we're looking at the exercise oncology part of it, but also then there's a mental health part of it, and then there's also a sexual health part of it.
Mhm.
And I think looking at all those pieces or reproductive health part of it for my younger patients who need to talk about like, what do I do if I'm 30 years old and I'm going to have chemotherapy and my ovaries are going to die and all those things that's a whole other ball of wax. But I think that as we move forward, more cancer centers are going to have a very specific provider or providers that can help out with talking about these things and being comfortable with prescribing patients with a history of a hormone fed cancer, which is not just breast cancer. Brain cancer can be hormone fed. There's lots of cancers out there that can be estrogen receptor positive. And so all of those people need to have conversations about whether or not this is the right choice for them.
Mhm. Yeah.
So,
I love to see that. I love to see that trend with,
mhm.
more interdisciplinary comprehensive cancer centers. And that just goes to show that, treatment and early detection and, the way that we are looking at cancer now is more of a chronic disease. And
Mhm.
so how do you manage that long term so that, like, as you said, they have the best quality of life possible?
Right, because it used to be we didn't live long enough for
Right.
them to worry about what it was going to be like for us 10 or 20 years down the road.
Right.
And now that we are living long, fruitful lives because we have such good treatment options for breast cancers, how do we make those lives, how do we make those years the best we can?
Yeah,
Yeah.
exactly. Exactly. So, all right. Well, thank you so much. I found this so fascinating and so interesting. And as someone who is in the throes of perimenopause, very, very helpful.
Yeah. And I think it's applicable for women, both with and without a history of cancer. But um, I just want to encourage all of you guys. It was a really big blow to be in this position. at any point in our lives, but to have it affect us in so many different ways on a both physical, mental, spiritual, all the levels, right? Um, and to just feel a little bit of yourself coming back and feel a little bit like you can be a semblance of the person you were before everything seemed to be taken away from you
Mhm.
is really important. And I encourage you guys that it can happen and we can help you. So thank you for taking the time to listen to me babble upon. And if you have specific questions that I didn't address and you want to send them to Karen, you're more than welcome to do so, and I can try to address them. But talk with your care team about any of your concerns too, because they should listen. And if they don't, it's time to find somebody who will.
Yeah. Well, thank you. I just am so thankful for you and for your friendship and for, just what you've done tonight.